Hello and welcome to the UVA Medical Center Hour. I'm Justin Mutter, Director of the Medical Center Hour, which is a program of UVA's Center for Health, Humanities, and Ethics. We're delighted to offer today's event in partnership with the Brody Medical Education Committee, which has for many years sponsored this Brody Lecture, a fitting keynote to a week during which we celebrate recent accomplishments in health professions education, while also looking to the future to catalyze ongoing transformation in service to students, trainees, to patients, and our communities. As is standard for the Medical Center Hour, continuing education credit can be claimed for today's event, and we invite you to follow the directions that will appear on slides at the end of today's event in order to do so. Today's event is a Zoom-only webinar format, and participants can enter questions in the Q&A tab at the bottom of your Zoom screen, which will be monitored by me as our panel continues its discussion. Speaking many years later regarding his seminal 1961 article on the ecology of medical care in the New England Journal of Medicine, Dr. Kerr White, whose papers and library reside here in UVA's historical collections, noted that for many decades following World War II, quote, the United States was running massive medical education industries for future doctors with little to no information about the 85% of medical care provided to ambulatory patients. Dr. White would devote much of his career to studying healthcare ecosystems as a way of illuminating how we should teach and how we should learn in the health professions. Such work naturally uncovers big questions. Toward what goals should we educate? How do we build thriving learning communities capable of meeting the unique and diverse healthcare needs of the 21st century? Today, we're honored to welcome Dr. Russell Phillips to help us navigate such questions. Dr. Phillips' extraordinary career in education and primary care transformation has extended the legacy of Dr. White and so many others. He is director of the Center for Primary Care and the William Applebaum Professor of Medicine and Professor of Global Health and Social Medicine at Harvard Medical School. He's a general internist at Beth Israel Deaconess Medical Center, where he provides primary care and healthcare associates, which is a large teaching practice. He has been a leader in innovation and practice and payment in primary care, implementing new care models for patients with chronic illness, and using microsimulation, testing the impact of global payment on value. He is a prolific educator and a prolific researcher with more than 250 peer-reviewed articles in circulation. Before I invite Dr. Phillips to the stage, let me also introduce our two panelists so that we can jump right into discussion following the completion of Dr. Phillips' lecture. Dr. Evan Heald is Associate Professor of Medicine and Director of the Brody Medical Education Fund, a general internist who has dedicated many years of service to patients in our Central Virginia communities. Dr. Heald is also a longstanding leader in undergraduate and graduate medical education at UVA. We'll also be joined by Jacqueline Carson, who is a fourth-year medical student here at UVA, who exemplifies the spirit of Dr. Phillips' title for today's presentation, Students Leading and Co-Creating Change. Working with faculty, students, and residents across our institution, Jacqueline has been instrumental in developing and optimizing clinical services at The Haven, which is Charlottesville's multi-resource day shelter for those in our community struggling with housing insecurity. And now please join me in welcoming Dr. Phillips to our virtual stage.
Let's see, can you see my screen? Okay, great. Thank you very much. Thank you for that kind introduction. And just before I get started, I do want to say that it's been a real pleasure for me to be visiting the University of Virginia. I thank especially Dr. Heald, who's really been a wonderful host. And I've had an opportunity to meet with the leadership of the school, with incredible residents and students and faculty, and it's really been just a really wonderful experience, and I thank you for that. I was especially impressed. We had shared stories last night of the change that students and others are creating at UVA, and these were incredibly inspirational and included one by one of our panelists about starting a program for care for the homeless and a homeless consult service at UVA. And these are just, amazing examples of the kinds of work that students and faculty can do in creating change. Before I get started, I do just want to mention that I have two potential conflicts that they really aren't related to this talk, but I should just mention them. One of the things that we do in the Center for Primary Care is we do advise startups and help to encourage innovation and entrepreneurship. And I'm involved in two companies. One's called Bicycle Health, which is a telemedicine company that focuses on treatment of patients with opioid use disorder. I was interested because it's really a company that can support primary care practices in this activity, as well as Grow Therapy, which is helping therapists who are accepting only private pay move to health insurance so as to improve access to behavioral health care. I also serve as a scientific advisor to the MAVEN project, which is a program that the center helped to start, which provides telemedicine consultations to primary care clinicians in community health centers to improve access to specialty services. The objectives of today's talk is really to apply Kotter's change management framework to create change and examples of the student's role, to understand the work and organization of the Center for Primary Care, to understand critical elemental components of primary care education with examples from the Harvard experience, and then to understand other examples of changes created or co-created by medical students in primary care at Harvard Medical School. And really the focus is students and residents as change agents. The framework really for change is borrowed from John Kotter. And yesterday, one of the residents asked me about really a curriculum for advocacy. And this very much is a curriculum for advocacy and change. It was published in a book that John Kotter, who's at Harvard Business School, wrote called Leading Change. And there are really 8 steps. One is establishing a sense of urgency. Another is creating a guiding coalition. A third is developing a vision and strategy. A fourth is communicating the change vision. A fifth is empowering students. And this is really because I'm focusing on the role of students for broad-based action, generating short-term wins, consolidating change and producing more wins, and anchoring new approaches in the culture. And as I reflected on the changes that were presented last night in terms of inspiring new programs at UVA, I think many sort of have gone through this, whether it was intentional or not. It really illustrates the importance of this as an approach. First, I'll talk about the Center for Primary Care and sort of the process for change. And it went through Kotter's 8 steps. I won't follow the slide precisely, but I do want to tell a story of the center because I think it's really instructive. As I've reflected on sort of the work at UVA, I do understand that there's an important center structure at UVA, and really do believe that having a center that focuses on primary care would be a major step forward. And would love to sort of share our learnings as well as potentially be helpful if that is a process that UVA wishes to go through. In terms of establishing a sense of urgency, what happened first, and this was about now 12, maybe even 14 years ago at Harvard, where the then dean, Jeff Flyer, was facing some financial challenges, and we had a division of primary care at the medical school. It's important to understand that the division did not provide any healthcare services because the medical school itself does not provide healthcare, but it's rather healthcare is delivered at the hospitals, and the medical school is really the academic home. And so the primary care division was an academic home that focused on education. And what ended up happening was that the dean, in a time of fiscal uncertainty, essentially zeroed out that division, or got rid of the division. And it became sort of the focal point for students and residents to organize, to circulate a petition initially, to engage others more broadly, calling for support of primary care at Harvard Medical School. Students really, understood that primary care is the foundation of our healthcare system, that there should be increasing focus for primary care at Harvard Medical School, and erasing a division of primary care was really the wrong direction to go. What students did next was to create a new organization, which was called the Primary Care Working Group. They did have faculty involvement, but it primarily consisted of students and residents. And they held meetings with various deans and opinion leaders. And in response to that, the dean created a task force that really focused on the role of primary care at Harvard Medical School. What was interesting then is that the dean was responding primarily to students, and it points out, I think, the power of students in shaping programs and in motivating change at our medical schools. I had the privilege of serving as a co-chair of that task force along with David Bates. We had students, faculty, community members on the task force, and our job was to develop a vision and strategy for primary care. And it was actually, the process was informed by community organizing, and we had several students who had actually worked as community organizers prior to coming to medical school, and they were important advisors. We actually sort of built on the community engagement by holding town hall meetings, which had never been done at Harvard around, sort of the work of an advisory group. And so it was something new and different, but we had town hall meetings both to engage the community, to solicit their thoughts, and to eventually present our vision for change, to test it with the community, and then to iterate it on it to make sure that it reflected the wishes and desires of the community. And what the task force really tried to build on was the concerns that were raised by students, as well as the interests of students. And one was to build a community at Harvard Medical School that focused on primary care. And this would be a broad community that united across the hospitals and primary care specialties to train leaders and future leaders in primary care transformation, to advance primary care practices, and include both education and research in a way that was in proximity to students. We communicated the change vision through town hall meetings and got feedback as well, as I mentioned. And empowered students for broad-based action. The dean, in response to that, actually was able to raise $30 million to fund the center. And these dollars could have gone somewhere else, but I think the dean understood that this was a strong desire of the students. And within the center, we created a student advisory committee that the students were renamed the Student Leadership Committee. And they did that almost immediately because they saw themselves less as being advisors, but really leaders within the center. As the center was created, I became an interim director, eventually became director of the center. I had a co-director, Andy Elner, who continues to work with me, although he's also at times been involved in entrepreneurship. And we developed a number of programs, and I'll talk about those in a moment. In terms of creating short-term wins, the students created a leadership training curriculum. The center began an Innovations Fellow program, which was really a leadership training program for junior faculty in primary care transformation. We created a program called Agents of Change, where students engage with faculty in community health centers, and also the Academic Innovations Collaborative, which I'll be talking about on Friday, which was really an effort to convert all of our academic practices to patient-centered medical homes, with the idea that we could both improve the patient experience, but even more importantly to our students and their education, is create really an optimal environment from which our students could learn about primary care. We also anchored new approaches in the culture. We sort of formalized the Student Leadership Committee as a primary care progress chapter. Primary Care Progress is a national organization that supports primary care leadership skills. The students became involved in revisit, orientation, and eventually recruiting new junior members. This slide gives you a sense of where we are now, in the center, and it's a busy slide, but mostly wanted to use it to show the areas of work and the mission of the center. Our goal is to save and improve lives through primary care, and our own work has shown that primary care, more than any other specialty, does save and extend lives. We've shown that the number of primary care physicians at the county level is strongly related to the life expectancy of people who live in those counties. And that's after adjusting for all other factors that we know affect life expectancy. And that relationship was true for primary care doctors, but not for other specialties in medicine. We also have shown that by increasing the number of primary care physicians in communities that are underserved, we can actually add as much as a year to life expectancy. So primary care is really critically important as an equity issue and as a life expectancy issue. The goal of the mission of the center is to foster a dynamic community at Harvard Medical School to promote and support primary care resilience, equity, and value in order to improve health and well-being. And so all of our work really does focus on the issue of resilience or burnout, on equity and value, which are three main issues in primary care, or three things that primary care is really set up to address. We have different areas of work, and those are outlined in our goals. One is around strengthening education, leadership, and advocacy. Another is advancing innovation and practice transformation. And this includes our entrepreneurship work, optimizing discovery or research, promoting equity and anti-racism, and then, of course, the internal issues of creating a culture of endurance and strengthening of the center. To describe our current work in practice transformation, we do work in vaccine equity. We have national collaboratives where we've been working with practices to address COVID vaccination and equity in COVID vaccine nationally. We've also, in Massachusetts, been working to strengthen value-based care in community health centers. Our community health centers are rapidly moving to value-based care, so helping them to make the transition from fee-for-service to value-based care. And we're doing something similar in assisting independent primary care practices and making that same transition. In entrepreneurship, we've developed something called the Health Tech Fellowship, which is a one-year program for students who want to become entrepreneurs, and it's for a deep immersion in healthcare. Although there's at least one physician or clinician on the team, we also bring in engineers and people from other backgrounds to deeply immerse in healthcare, with the idea that they'll either have a role in creating a company or working with others on entrepreneurship. We have run the MIT Harvard Boot Camp, which is a short course in entrepreneurship. We have pipeline high school programs, which train students in disadvantaged areas about opportunities to become entrepreneurs. And then we advise entrepreneurs who often are medical students or others from the Harvard ecosystem. In terms of advocacy, equity access and advocacy, we work with community health centers in Arkansas, West Virginia, and Oklahoma on care of patients with chronic illness using Project ECHO, which is an approach to continuing medical education, which is evidence-based, as well as population health learning collaboratives, and advocate in Massachusetts for value-based payment options and enhanced primary care investment. I'll talk a little bit more about that on Friday. In education, we house the Home for Family Medicine. We unfortunately don't have a family medicine department yet at Harvard Medical School, so we are the home for family medicine activities and the Family Medicine Interest Group. We've developed a new primary care curriculum, which I'll speak about shortly. Have leadership training programs, and then we house the Student Leadership Committee, which is an important agent of change within the center, and I'll describe their work as well. In research, we do program evaluation. We look at the impact of access to primary care on life expectancy and other factors nationally. And then we have a grant on patients as part of the AHRQ Patient Safety Learning Lab on closing the loop on referrals, tests, and symptoms. And then we have an operations component as well. In terms of some of the early wins of the center, one was really developing the primary care curriculum. And what was really interesting is as we developed the Academic Innovations Collaborative and transitioned our practices to patient-centered medical home, our Dean of Education really began to think about housing some programs that had traditionally been in the hospital in primary care practices instead. And so with that, the Foundational Continuity Clinic was created, and the Foundational Continuity Clinic became an opportunity for students to learn both about how to take a history and do a physical exam, but also to learn about primary care practice and primary care teams. So now, very early on in the medical school curriculum, the students start the Foundational Continuity Clinic with an idea that they'll be working with a preceptor, which will then continue in year 2 and 3. At Harvard, there's a 14-month preclinical period, and then the students move into what's called the principal clinical experience. Part of the principal clinical experience includes the primary care clerkship, and so the longitudinal path is really one of working in the continuity, in the Foundational Continuity Clinic, and then moving, from that into the primary care clerkship, ideally with the same preceptor. So there's continuity both with preceptor, but also with patients. So the same patients that you're potentially, as a student, learning to take a history and physical on, you're eventually beginning to care for in terms of the problems that they're then coming into the practice with. Ideally, and I'll mention this, we will be talking about a 3rd and 4th year curriculum, which would provide longitudinal primary care contact over time as well. Right now, we don't have that, but we certainly see a need to do that. The goal was to develop a blue sky template for the key components of a primary care curriculum that would be generalizable to other institutions and would inform a set of competencies that all students should attain in their training. The group that put this together, which included students, knew that this should include longitudinal integration of students into primary care practices, eventually span all 4 years, be developmentally progressive, and provide the foundational competencies for all students and expanded competencies for those intending to focus on primary care. In 2014, a working group of 15 expert educators from HMS and the main primary care fields came together, and they joined with 5 medical students to create the curriculum. They reviewed the available literature, as well as national undergraduate curricula in internal medicine, family medicine, and pediatrics. And from that, 11 core themes emerged. And they fell into 3 categories, and those included care management, specific content expertise, and the role of primary care in the health system. And the goal really became one of being certain that all of these things were covered in the primary care curriculum. And under care management, to go through these quickly, longitudinality, generalism, and the central responsibility for managing care, as well as developing a therapeutic alliance and developing communication skills. Under specific content expertise was really learning how to approach acute care problems, chronic care problems, wellness and prevention, and mental and behavioral health. And then the role of the primary care in the health system was really thinking about systems improvement and quality improvement skills, interprofessional training, and population health. This was published, and you'll note that there are students who are authors of this as well, as the blueprint for an undergraduate primary care curriculum in academic medicine. And this curriculum has been adopted elsewhere. It was certainly implemented at Harvard Medical School. However, as we've now evaluated that curriculum, we've learned some important things, and I'll share those. One is that students in all classes reported high rates of preparedness with building therapeutic alliances and communication skills, but felt low preparedness in some of the more complex and advanced skills of systems improvement, population health, and care management. The level of comfort in approaching disease conditions was lower than that in approaching conditions seen in inpatient medicine. And there also is lower levels of satisfaction with the primary care curriculum than with the overall curriculum. And so we're in the midst of now developing a new curriculum at Harvard, and again, have students engage in this process. The Student Leadership Committee will be potentially, and a number of the students will provide a number of students who will engage on this. And what we're really working on is explicit teaching of competencies as part of the core curriculum redesign, improving the experiential learning options for advanced students, considering a career in primary care. So we're even talking about a primary care track at Harvard Medical School, where Harvard has generally avoided the language of tracks. We're talking about a broader array of pediatric exposure, including ambulatory longitudinal practice. We want to enhance teaching of healthcare systems and population health, and are right now as a center advocating for expansion of the curriculum into the third and the fourth years. So I should have mentioned that the work in the center that it focuses on curriculum redesign in terms of faculty is led by Sarah Fazio, who leads one of our one of the student groups at the students are organized into institutes at Harvard, and she leads one of those and is a professor who focuses also on medical education. And she's led education within the center now for a number of years. The next work, so speaking about attribution, is led by David Duong, who is a faculty member in the center, but really working for and with students. And this is just another example of curriculum or work that's being really led in many ways by students. And this is the Office for Community-Centered Medical Education. What happened here is something very similar to what happened in the creation of the center, and that's that students organized. They recognized, especially in this day when there's such a focus on social justice, that Harvard was not trusted by the local community. The engagement of students in the local community had not always been something that the community was benefiting from, and that often the students' connection with the communities were one-off and did not persist over time, and wanted to find better ways for Harvard to connect with the community and really serve community needs. And in response to that, the dean came to the Center for Primary Care, because the center, of all places at Harvard, was most connected to the community, and asked if we would lead the work with students so as to develop what became the Office for Community-Centered Medical Education. And the goals of this office and this educational program was to train the next generation of leaders in community health through development of relationships of trust, mutual respect, and open communication with our communities. Doing this through partnerships with local communities that allows all students to appreciate the lived experiences of people living in our communities, and a belief that all physicians must strive to understand the context of their patients' lives and how to deliver care appropriate to their individual circumstances. The journey very much replicated what we'd done again, in the center. There was a town hall component, there were surveys, petitions, a steering committee that was composed of 4 faculty, 4 community members, and 4 students. And they came up with a vision and, for what this office would look like. And now we're trying to actualize that vision. The students did a survey that showed that many students agreed that there should be a program that provided mentorship and community engagement, and that would be important to their medical education, that there should be an office for community engagement, but that only 31% felt that they had the adequate tools to engage in meaningful community-related work. And so they wanted the office to implement a novel educational program with regards to social medicine, racial justice, and advocacy, and also wanted to work with community organizations as they engaged in scholarship and research focused on community-centered work, but really using approaches of community-based participatory research. So this would not be following an agenda of the students or their faculty mentors, but rather would follow the agenda of the community members. The goals were to enable and foster meaningful engagement, to integrate in a student accessible way, and to provide guidance, infrastructure, and resources. So in a way, this really represented the Harvard Medical School investing in community organizations in a long time, in a sort of committed way over time, and committing to have students and faculty who would be serving and working with community organizations. Some of the, just to give a flavor for, what students were saying, one student said, "I'm getting exposed to a side of Boston that I do not normally see, the side I hear about on NPR or National Public Radio, but feels so far from the tree-lined street where I live in Cambridge. I've met many patients in primary care clinic who live in these communities or struggle with drug addiction, but I have not myself spent time in these communities." And there is really an interest in the part of students in spending time in these communities, which are actually just adjacent to Harvard Medical School. That is a program now which is in its sort of continuing in its design phase. The students are working with faculty member to identify the community organizations that would become part of these partnerships. And as those develop, we'll begin to define an agenda for work with those community organizations. So that work is moving forward. And then a final program that I want to describe, and we'll do briefly, is the Student Leadership Committee. Yesterday, we had a session with students, and had several students join from the Student Leadership Committee. And my takeaway from that is that there may be interest at University of Virginia in sort of doing something similar. And the Student Leadership Committee at Harvard Medical School is very interested in supporting any initiative in this area also at UVA. But this, their work began, as I mentioned, with the creation of the center, where it's really Harvard Medical students who are advocating for, at that time, reinvestment in primary care. The dean had, as I mentioned, cut any investment, and the students were really wanting the dean and the medical school to reinvest. And in 2010, based on the work of students, the Center for Primary Care was founded. The students formed what became the Student Leadership Committee. I did envision that the students would be an advisory committee to the center, but when the students first met, they said, we want a greater role, and rename themselves the Student Leadership Committee. And ever since, have really been developing their own agenda year by year. In most years, it is collaborative with the Center for Primary Care, but we don't require that to be the case. And as I've mentioned, we've learned a lot from what the students do, and oftentimes try to replicate that. Early on, the students partnered with Primary Care Progress, also with the AMA chapter, to host advocacy trainings. They also, although not shown on this slide, very early on became interprofessional, and we learned from that as well. The center itself became interprofessional, which has been a challenge because we don't have the benefit at Harvard Medical School of having a nursing school or other health profession schools other than dentistry. So the SLC, initially was dentists, it was dental students and medical students, but it's been expanded to include nursing students and social work students and others from other professional schools in the Boston area. The SLC partnered with Boston Healthcare for the Homeless in addressing homeless care needs. It formed an immigrant and refugee health and advocacy panel. And I don't mean these to, identify everything the center did, the SLC has done, but rather to illustrate some of the work that they've done on advocacy. Starting in 2017, we sponsored a trip to Washington, which happened annually until COVID, and hopefully we'll be able to resume to learn about advocacy and policy in primary care. They hosted an Achieving Health Equity in an Unequal Country symposium. They launched a Racism in Health project and developed advocacy work around the intersection of racial justice and health. We also in the center have an active program now around racial justice that we are, initially testing within our own group, really, as we all, as the center staff are learning more about white supremacy and racism within our own institutions and our own center, and how we can best address that. In that way, we've been learning from the students as well. This slide gives a sort of a sense of some of the work that have been done by students, and you can see it's pretty expansive. I won't go through it all, but you know, in the center, you can see the primary care curriculum blueprint, and that really was something that was developed by the SLC in collaboration with Sarah Fazio and other faculty. But you can see there are a number of programs that the SLC has created over time. Since the SLC began, there have been 260 individual members, 38% of them are interprofessional, and there have been over 300 programs that the SLC has actually delivered on. Early on, they developed a leadership training curriculum, which they've actually published on, and includes these 8 or 9 steps. Systems thinking, creating driver diagrams, leveraging data for practice improvement, lean management principles, leading and managing change, design thinking, giving and receiving feedback, and working and leading with interprofessional teams. This is a program that is led by students and is often led by senior students, and then it's replicated year after year by junior students playing a leading, becoming senior students and becoming the teachers. This slide just gives an idea of some of the student-faculty collaborations. I won't go through them all for the sake of time, but I have mentioned, you know, several of these already. I should mention that the 5th year that more than, I think, 70% of our students are at Harvard for 5 years. There's a 5th year scholarly project, and the SLC has been important in terms of creating programming opportunities for students who want to do their work in primary care. Just some testimonials by students, and I'll read just a few of these. You know, through the SLC, I was surrounded by a community of students who are role models, inspirations, and supports throughout medical school. I was able to contribute to original research projects, found and lead new committees within the group, and try my own hand at developing and leading creative projects. These skills have been indispensable as I shift into leading teams in the clinical setting and continue my research. And a third, I'll be forever grateful to the SLC for recognizing the importance of including non-medical students in the organization and providing a space where all healthcare students can come together to learn, grow, and flourish to become patient-centered providers. This is not to say that we don't have challenges, and our biggest challenge now is sustaining the work of the Center for Primary Care. The center is actually funded through a combination of philanthropy, of programs, in revenue. We run programs on leadership training, on practice transformation, on innovation and entrepreneurship, all of which raise funds. But those funds are insufficient to run the program, and so we have grants as well. So it's a combination of grants, philanthropy, and program income, and need to constantly be thinking about additional philanthropy as to continue to support the work of the program. We don't have an endowment that supports the program, so this is an important focus of my work. We're continuing the promotion of primary care equity, resilience, and value, both locally and nationally. I've become a member of a group nationally which includes leaders of centers from around the country that focus on primary care. There are about 15 centers like ours. We'd love there to be others. So if University of Virginia wanted to participate in that, we'd certainly welcome that. We engage students, residents, and training patients in the Harvard primary care community, as well as the larger Harvard community in our work. We want to do better in that. We want to promote family medicine interprofessional team members as an important part of the primary care healthcare workforce. We're actually working hard to create a department of family medicine at Harvard, which has its own challenges, but we think that's important as family medicine represents 40% of the primary care workforce. We want to attend to needs of staff while addressing diversity, equity, inclusion, anti-racism, and white supremacy cultures I mentioned. And then we would love to be partnering with other schools to strengthen our ability to advocate for primary care, both at the state but also at the national level. So in summary, just want to say again that I do think Kotter's principles give an important construct for changes that includes community organizing. That as I've met with students and residents here, I've really tried to impress upon them the power that they have and within our institutions, encourage them to lead the way. But for us as faculty to provide active accompaniment, support, mentorship, to engage with leadership in a manner that builds support through engagement and partnership. I've certainly tried hard to do that with the leaders at Harvard, where our current dean is entirely focused on the role of Harvard Medical School in supporting healthcare transformation, but to recognize that change is slow, especially it seems in academics, and to be patient and establish a reasonable timeline as we work to create change. And then be sure to align our work with institutional values while identifying and working closely with potential and current funders. So I will stop there. I want to again say it's really been a pleasure for me to be here, and I will turn it back to our moderator.
Thank you so much, Dr. Phillips. There's a lot to discuss and a lot of work that the center has been doing, and the interface between education and primary care and advocacy. I want to just ask our panelist, Jacqueline, to comment a little bit and just maybe have some questions of her own as we get started here in the Q&A.
Thank you so much, Dr. Mutter and Dr. Phillips. It's so wonderful to hear about all the work that you all have been doing, and it's so inspirational. And I hope that we at UVA can take some of the notes from you and implement them here. I was curious, I know you mentioned this briefly when you were discussing community-centered medical curriculum, but I think we as medical students and healthcare professionals have a pretty good understanding that we're going to be advocates for the communities that we plan to serve, and especially where we are training. And I think one of the best ways to become advocates and learn about the problems facing our communities is by getting a better understanding of the specific social determinants of health in our neighborhoods. And a lot of that is by having boots on the ground and being involved, meeting people with lived experience and seeing the facilities by ourselves. However, in the times of COVID, I have personally found it difficult to find in-person at volunteer activities and being able to coordinate those. But as a result, it's also bred really incredible amount of creativity for students and healthcare workers to create new interventions that were out of the box and not really thought of as attainable before, specifically to address our community's really evolving needs in the time of this pandemic. I was wondering if you could talk about some of the projects that you've seen implemented that have come out of the COVID pandemic, and kind of the barriers that were present in creating them, and how students and trainees were mentored throughout those processes.
Sure. Some of the things, that's a great question. And I think, you're exactly right that I think it's really important that students have their some boots on the ground, as you say, in communities, so we can sort of see what the lived experiences of community members and see what their needs are. I think we can also learn that, by the way, in our primary care practices, where, hopefully we're screening for social determinants of health and really getting a chance to talk with patients. I mean, it's not just in primary care, but in all of healthcare, that it's important to be screening for and understanding to what extent our, patients are experiencing, food insecurity, challenges with housing, legal issues, really all of the kinds of things that, potentially are social determinants, but affect the kinds of healthcare and health that our patients potentially, have access to. Some of the things that have gone on in the center in response to COVID, one is really developing, the students have developed sort of curricular materials that have gone national, that have provided sort of continual updates on sort of vaccines, on treatment for COVIDs, on, now on ambulatory treatments for COVID, and so have become, a real resource. Another thing that students, I think less so at the S and the SLC, but, I work with others at other medical schools, and certainly vaccination has been something that our students have been, very involved in, and working with community health centers to provide vaccinations. In Massachusetts, at least, community health centers have had access to vaccines, but have not necessarily had the workforce, in place to administer vaccines. So students have gotten engaged there, and that's been important. We've also had, sort of events at community sites to provide vaccination as well. And these, are certainly in the community where there are issues of equity in terms of access. So students have played an important role there, as well. I think it has been a frustration for students, though, that it's been difficult to engage. Our students want to get into community health centers more than they have, and that's been, a challenge. Our students want to travel to Washington and engage, and, that's a challenge. Some of that can happen virtually, but there's nothing like being there. And so I think we're all looking forward to our post-COVID, what hopefully will be a post-COVID experience where we can recover, some of those sort of hands-on and in-person activities.
Thank you, Russ. And I was struck by, in your comment, just the degree to which entrepreneurialism is sort of an ongoing feature of the center's work, not only through leadership and training, but also in some of the programmatic aspects of what the center is trying to do. And it just made me reflect about the nature of primary care transformation in the United States, where we have quite a few private sector entities, including some funded by venture capitalist entities that are really innovating in the primary care space. But a lot of this is going on outside of academic medical centers, is going on sort of very much in the private sector, and not connected in meaningful ways to health professions education. I'm curious if the Student Leadership Committee or others within the center have explored that and that interface, and how kind of what's going on in the private sector could very much be better synthesized with learning opportunities for students and trainees.
Yeah, it's a really great question, and a real challenge. At Harvard, most of, or I should say the academic medical centers really have a strong hold on our students, and the student experience of primary care is largely there. However, students can elect to, go other places during elective time, often in their third and fourth year. And many of our students are, electing to spend time at what are essentially, new ways of delivering health care, like Iora Health or Chen Med or Firefly Health, which is actually started by my co-director, Andy Elner, and is a local sort of virtual primary care organization. And, I think we will see more of that. And I actually think as we prepare our students to practice in primary care, what will become primary care of the future, it's going to be important to expose our students to these new approaches to primary care, and even to, as I mentioned, getting our students engaged in thinking about what these new approaches might look like, and even having a role in sort of creating some of those new approaches as well. That's in many ways the rationale for us to getting involved. We felt that changes within our existing practices occur slowly, but there's, a ton of activity, both in the for-profit and nonprofit space, elsewhere. And we wanted to play a role in that and potentially make it an educational platform as well. I've actually invited Andy Elner to come back to the center, who to sort of bring together entrepreneurs so that we can really think about how we can organize our students' exposure to new approaches of delivering healthcare and primary care in particular, because I think that's an important experience for students.
Well, I invite any of our participants. We've had a couple of questions start to come in. But Dr. Hield, I know you might have a question or two of your own. Again, please go ahead and put your questions in the Q&A tab, and we will get to them if we are able.
So Russ, I want to thank you for decades of work in medical education and practice improvement and advocacy. I feel like we could keep you busy here for a whole week teaching us. In fact, that's what we're doing. That's why you're our Birdie Scholar. So thank you for that. I have a two-part question. I'm going to describe a hypothetical medical school applicant. Let's say she grew up in the DC suburbs. Her mother is a Black plastic surgeon. Her father is let's say, a Pacific Islander in the Foreign Service. She spent summers organizing mission trips to help her mother correct devastating craniofacial deformities. She wants to be a plastic surgeon. She's first chair violin. She rode stroke in the Princeton Lightweight 8. She teaches English as a second language. Got a research internship at the NIH. So aside from the Princeton thing, she seems like a pretty solid applicant. Why does she need primary care in her medical experience?
I'm sorry, say the question again.
Why does she need primary care in her medical experience?
Yeah, so I guess the first thing is that although students come to us with specific interests, it's never clear what students are going to decide to do. And, as an example, my colleague, David Duong, who is, working in the center, he's a Vietnamese, his family immigrated from Vietnam following the war. He's first generation. He was in a pipeline program. He fully intended to become a surgeon. And he's now a, primary care physician. He was a member of our SLC and understood and came to understand the importance of primary care, and so changed what he was going to do. So, there's always a possibility that this student will elect to do something different, and exposing that student to primary care is, I think, critical. The other, piece is that I think whatever we do in healthcare, primary care really exposes you to systems thinking, helps you understand how, the healthcare system operates. Certainly the role of primary care in developing trusted relationships with patients, and we're the ones who are going to be advising patients as to where to go for plastic surgery if that's what you need, and how to get through that. And plastic surgeons, I think, need to, no matter what you do, need to understand the role that primary care has in directing our patients to services, to preparing our patients for those services, and then following up with those patients as well. So the key role of primary care is something that should be understood, whether or not you end up practicing primary care or not. I also think that the curriculum of primary care, which includes quality improvement, is applicable everywhere. Certainly, as I mentioned, systems thinking, leadership training, all of those things are important skills for medical students, no matter what they end up doing.
And I guess the follow-up is, if we're trying to recruit a diverse class, what does the perfect candidate look like if we're also trying to train people to serve in Deerfield, Massachusetts, and Big Stone Gap, Virginia?
Yeah, so I think, we obviously, we have a challenge in terms of trying to recruit a diverse workforce, and diversity itself, is really important. And I know UVA, certainly Harvard Medical School, is focused, on that as well. So I do think that medical schools, all health professional schools really need to be recruiting for diversity. And, we probably even, we need to do that more than we even do. I didn't mention the recommendations that came out of the National Academy of Medicine recently, but the National Academy of Medicine has actually advocated for creating more residency programs within underserved or within communities where people live and work, with the idea that often our residents will stay in those communities to practice. So having teaching health centers and and taking advantage of HRSA programs like that, at least for residency training, are really important, and creating linkages between our medical schools and areas that care for diverse populations is really important.
So I'm going to try to bring together a couple of questions that have come through from our participants on Zoom and into sort of one question. And this has to do with not only the hidden curriculum, but some not so hidden curricula that exist in many schools of medical education, nursing education throughout the country. And so the question is what about subspecialty bias that is built into educational systems and curricula? One participant asked, it seems like there is a lot of dissuasion from people entering things like family medicine, as one of the primary care specialties, as an example. And so how should we, as schools of education, address these biases that have existed and built up over time and been sustained?
Yeah, I recognize that those biases exist. They certainly exist at Harvard, as well. I do think it's an advocacy role for centers like ours in terms of promoting and having people understand the value of primary care. I think it's, people often are trying to train people to do what they do. And so to some extent, it's a, bias against primary care, but it's often a bias to replicate yourself in terms of what, you'd love to see your students be doing. And our students are spending so much time with specialists that it's sort of, just feels like they're always encouraged to be specialists. And as I say, I think that's a reason to be exposing our students more to primary care, so that they can potentially combat that. I think, though, we also need to make primary care more attractive for our faculty so that our specialists are seeing primary care faculty who are happy, content in their work, and feel good about what they're doing. And oftentimes that's not the case right now because primary care is undersupported, it's undercompensated, and those issues need to be, addressed so that primary care, looks like and looks to be a more satisfying and rewarding career. So that's really, something that we need to do as educators and advocates. I do think that's the direction that we'll be moving in healthcare, but we need to obviously improve on that sooner rather than later.
And relatedly, I think this is coming through too in many of the conversations. I'm sure that this is hard to answer, but I think there are many schools of education, not just in health professions education, but our universities and colleges more generally that are thinking hard about how do we interface with our communities better and serve them better and really get outside of our walls and be in our communities to serve them and to learn in so doing. What is sort of the one, if you were to boil it down into this one thing that is critical that we should all hear about that effort, because that is an effort, of course, that's multifaceted and takes time and is must be done with a lot of care and concern. What's the one thing that you would say that your team has learned with some of these outreach efforts and connecting to communities?
Yeah, so I think, though we haven't actualized it yet, I think it is a matter of, identifying, and sort of we heard that somewhere from Jacqueline as well, that we need to, identify, community needs and then respond to those needs in a serious and ongoing way. Harvard, as I mentioned, has a challenge. If you just look at the architecture of Harvard, it almost turns its back. There's a solid wall facing Roxbury, and everything faces inward in the Harvard quad. And that's just, needs to be corrected and addressed. And I guess what I would love to see is, Harvard building a community clinic in Roxbury that actually serves the needs of that community and is there really to serve those needs, and works with community health centers and helps to, sort of correct the injustice of the role that Harvard has played in years past. I mean, that's particular to Harvard, but I think it's actually true for many of our medical schools as well. And not necessarily to do it solely through a free clinic where all the work is done by students, but really to invest in a way that is a continuing way where faculty are there with students and providing a high quality care that we're all proud of and is serving the needs of the community.
Well, thank you. Again, we are unfortunately out of time. I want to thank you all for attending and participating in today's Medical Center Hour, and thank Dr. Phillips, as well as our excellent panelists for this conversation. And as always, as we say every week with Medical Center Hour, please continue the conversations that have arisen in the course of this hour with your communities, with your colleagues, and throughout your networks. Please join us next Wednesday, same time, same Zoom link, as we welcome Professor Keith Welu from Princeton University. He's the current president of the American Association for the History of Medicine, and he will speak to us about his extraordinary new book, Pushing Cool, Big Tobacco, Racial Marketing, and the Untold Story of the Menthol Cigarette. Thanks again, and we will see you next week.
Thanks very much.